Hello my dear students, welcome back. Now we will be talking about aortic stenosis. What are the various causes for aortic stenosis? It could be congenital or secondary to rheumatic inflammation or maybe due to degenerative calcification of aortic cusps. In infant, children and adolescents, congenital aortic stenosis is the most common reason or most common cause. In young adults to middle-aged people, calcification and fibrosis of congenitally bicuspid aortic valve could be the reason. In middle-aged to elderly, we have calcification of bicuspid valve or rheumatic aortic stenosis, which is associated with rheumatic mitral valve involvement also. Importantly, please note, aortic calcification is most commonly associated with aortic stenosis. So wherever in the MCQ you find this word aortic calcification, you can think that the right answer could be aortic stenosis. So I repeat, aortic calcification is most commonly associated with aortic stenosis. What could be the clinical features of aortic stenosis? In symptoms, mild or moderate stenosis, patient is usually asymptomatic. When atrioventricular orifice has reduced to less than 1 centimeter square, symptoms appear. And what are the symptoms? It's a triad of symptoms. A triad of symptoms in which you get exertional dyspnea, angina and exertional syncope. Please understand there are n number of MCQs which could be framed like this: triad of symptoms, exertional dyspnea, angina and exertional syncope. This triad is most commonly associated with aortic stenosis. What is the cause for exertional dyspnea? You can understand when there is aortic stenosis means blood has to pass from left ventricle into the aorta, and here is the aortic valve which is getting stenosed. So definitely the left ventricle has to put more pressure. So there would be hypertrophy of left ventricle because of this stenosis. Left ventricle has to generate enough pressure to force the blood through the stenosed aortic valve, right? So because of this, there would be elevated pulmonary capillary pressure due to left ventricular compliance, and because of this, patient will get exertional dyspnea, means he will feel breathless when he is doing some exertion. Secondly, important feature is angina. Now, why there should be angina? As I have already stated, now in cases of severe aortic stenosis, left ventricle undergoes concentric hypertrophy, means the muscle mass increases. When this muscle mass increases, right, there is an imbalance between the supply and the demand. You can understand when there is hypertrophy, more oxygen is required through more blood, but this cannot be supplied, and because of this imbalance, patient might suffer from angina. There could be exertional syncope. What do you mean by this word? Whenever patient does exertion or does some work, right, the muscles are acting, because of which there is vasodilatation in the muscles, and there is not that corresponding vasoconstriction in the non-exercising muscle. You can understand there is vasoconstriction and the cardiac output is fixed because of aortic stenosis. So there is vasodilatation in the exercising muscle, and simultaneously the cardiac flow cannot increase. Because of this, BP goes down, and when the BP goes down, right, the patient can get syncope. So a triad of exertional dyspnea, angina and exertional syncope is very commonly seen in cases of aortic stenosis. Yeah, so triad, and there could be incidents of sudden death, and there could be episodes of acute pulmonary edema. What are the various signs which are seen in case of aortic stenosis? You get ejection systolic murmur. You can understand when the left ventricle contracts, at the time when it ejects blood into the aorta, at that time the blood encompasses or blood faces stenosis out here. So during the first phase of the ejection, you get a murmur. So this is known as ejection systolic murmur, which is seen shortly after the first heart sound, which increases in intensity to reach peak and ends just before the aortic valve closes. So delayed peak is a sign of severe aortic stenosis. Please understand, this ejection systolic murmur comes after the first heart sound, means the mitral valves are closed, aortic valve opens. As soon as the left ventricle, when it starts developing pressure, at that time blood flows from the left ventricle into the aorta, and at that time, because of the stenosis, right, the murmur is produced. Now left ventricle will have to contract a lot if the stenosis is very severe. So if there is a very delayed peak, means left ventricle has to contract a lot, and that's why there will be a delayed peak, and this delayed peak will give you an idea of the severity of the aortic stenosis. So whenever there is an MCQ which tells you that what are the guidelines by which you can assess the severity of the aortic stenosis, it will be not the intensity, it will not be the depth, it will be the delayed peak which would be telling you about the intensity or the severity of aortic stenosis. So delayed peak is a sign of severe AS. There will be slow rising carotid pulse. You can understand why slow rising. Left ventricle contracts slowly to overcome the stenosis. Slow peak. So slow rising carotid pulse, narrow pulse pressure, sustained forceful apex beat displaced laterally, which is because of the left ventricular pressure overload. You can also get fourth heart sound. So presence of fourth heart sound is seen in cases of aortic stenosis, and this fourth heart sound is because of the reduction in left ventricular compliance due to left ventricular hypertrophy. There is paradoxical splitting of S2, which signifies severe obstruction. There could be signs of pulmonary venous congestions, example crepitations, again because of the backward pressure which has been transmitted from the left atrium, from the left ventricle to left atrium and backwards, which can give rise to signs of pulmonary venous congestion. In ECG, you will get features of left ventricular hypertrophy. ECG features of hypertrophy are often gross, and you get downsloping of ST segment and T wave inversion, which is known as strain pattern. Please understand, this strain pattern is typically seen in case of aortic stenosis because the left ventricle is hypertrophied to a very great extent, right? Because of this, there is relative ischemia, and because of this ischemia, the left ventricle has strain pattern, and this strain pattern is shown in the ECG as downsloping of ST segments and T wave inversion. So this strain pattern is an ECG finding which is seen characteristically in case of aortic stenosis. Exercise testing is contraindicated. Please note this point. This point is important because when you are solving an MCQ, they will give you this as a negative answer. As I've already said, if you are doing exercise, right, you need more blood in the exercising muscle. So there will be vasodilatation in the exercising muscle. But the cardiac output is fixed. So if fixed cardiac output, more blood into the exercising muscle, BP falls, and you can have syncope or syncope, as some faculty says, right? So definitely exercise testing is contraindicated in cases of aortic stenosis. Correct. Chest X-ray may be normal. Sometimes enlarged left ventricle and dilated ascending aorta can be seen on PA view. Calcified valve may be seen on the lateral view. Absence of valvular calcification in an adult suggests that severe AS is not present. Again, this is an important point which you should note. If there is no valvular calcification, it means AS could be there, but definitely it is not that severe. So severity is correlated with the presence of valvular calcification. Calcified valve with restricted opening, and you can get an hypertrophied left ventricle also. It is useful in identifying abnormalities as MS and AR, which may be associated with AS, right? So you can get mitral stenosis and mitral regurgitation as associated anomalies also along with AS. So you can diagnose this. In case of Doppler can measure the severity of the stenosis. It can detect the associated aortic regurgitation. It can also measure the trans-aortic valvular gradient, pressure gradient. Cardiac catheterization, it is mainly done to identify associated coronary artery disease, may be used to measure the gradient between left ventricle and the aorta. Management. Irrespective of the severity of the stenosis, patients with asymptomatic aortic stenosis have a good prognosis and conservative medical management is appropriate. Anticoagulants are only required in patients who have atrial fibrillations or valve replacement with mechanical prosthesis. Patients with moderate or severe stenosis are evaluated every 1 to 2 years to detect the progression in severity. This is more rapid in older patients with heavily calcified valves. Such patients should be followed, and as the development of angina, syncope or symptoms of low cardiac output or heart failure has a poor prognosis, and this is an indication for prompt surgery. And finally, we'll be talking about aortic regurgitation. You know guys, aortic regurgitation is a valvular anomaly with full of signs and symptoms. You can get n number of signs and symptoms, and it is really interesting to learn aortic regurgitation. I'm quite hopeful that you would definitely enjoy this session with me. It is commoner in males. This could be seen in cases of congenital bicuspid valve, which is like there are congenital causes and there are acquired causes. In congenital causes, we have got congenital bicuspid valve, and it is more common in males. In the acquired causes, we have got rheumatic disease, infective endocarditis, traumatic rupture of the aortic valve. You can understand, if the valve gets ruptured, then definitely it can regurgitate back. Marfan's syndrome is an important condition where you can get aortic regurgitation, and I have seen n number of books have quoted quite many MCQs where they give an hint of Marfan's syndrome, or at times they talk about arm span more than the height. They will give you arm span 90 centimeter and height 86 centimeter. So arm span more than height is suggestive of Marfan's syndrome. So at times they will not give you Marfan's syndrome, they will give you this hint, and then if you can understand this, Marfan's syndrome should definitely click your mind, and then you can quote or you can come to the answer as aortic regurgitation. So Marfan's syndrome is an important cause where arm span is more than height. This can lead to proximal root dilatation and aortic root dissection. Because of this proximal root dilatation and aortic root dissection, you can get symptoms of aortic regurgitation. Syphilis and collagen vascular diseases as systemic lupus erythematosus and ankylosing spondylitis are again important causes which is associated with aortic regurgitation. And yes, not to forget, long-standing essential hypertension can also give rise to aortic regurgitation. Here you must be seeing in my slide, I have written no MI. I was forced to write this word because when I was going through MCQs, I had seen n number of MCQs where they have quoted MI as one of the causes for aortic regurgitation. I mean, which is the negative answer, which is not the right answer. So please take a note of this. All these conditions which I have told, congenital, acquired, rheumatic, traumatic, Marfan syndrome, blah blah blah. These are all causes for aortic regurgitation. But please do remember, myocardial infarction per se doesn't give rise to aortic regurgitation. So this will definitely help you if coincidentally you get this MCQ. With each systole can be appreciated in case of aortic stenosis. So you can see, patient has this bobbing movement like this, and the entire body, there is a jarring movement of the entire body, which is typically seen in case of aortic regurgitation. In mild to moderate AR, patient is aware of his own heartbeats, palpitation. Severe aortic regurgitation, we get breathlessness, angina, and bounding peripheral pulses. There are various signs which are seen in case of aortic regurgitation. First is Corrigan's pulse. What is Corrigan's pulse? The carotid pulse has a rapid rise in systole and a rapid fall in diastole. You can understand there is aortic regurgitation, right? More blood, it is going out during systole, but during diastole, because of the regurgitation, the blood goes back. So during systole, the pulse rises, and during diastole, it collapses suddenly, which is a characteristic sign seen in aortic regurgitation. So, Corrigan's pulse. Reduction in diastolic systemic arterial pressure can lead to syncope because of reduction of the cerebral perfusion, and it can also give rise to angina because of compromised coronary blood flow. Now there is Hill sign. What is that? Hill sign refers to disproportionate increase of systolic blood pressure taken in the legs as compared to that measured in the arms. Quincke's sign. Systolic blushing and diastolic blanching of the nail bed when upward tension is placed onto the nails. See, when we place this upward tension onto the nails, normally we see blanching. But in case of aortic regurgitation, there is alternate blushing and belching, blushing and belching. You can see onto the nail bed, which is Quincke's sign. Durosis sign, stethoscope is placed over the femoral artery with enough pressure to produce systolic bruit. Concomitant occurrence of diastolic bruit constitutes this sign. So if you are auscultating femoral artery, you just put stethoscope and put just enough pressure so that you can get a systolic bruit. Right? Bruit means which is an abnormal sound which is produced because of the turbulence in the blood flow. So once you will be applying some pressure, you will get systolic bruit. At that time only, if you are getting a diastolic bruit only, this constitutes the Durosis sign. Then we have got de-Musset sign, head nodding with each pulse, which I have briefed you before also. Then there is pistol shot murmur, that is auscultation over femoral artery gives rise to pistol shot pulse. So if you auscultate the femoral artery, you will hear typical sound like pistol shots, tuck, 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 tuck. Murmurs, early diastolic murmur which is best heard to the left of the sternum during held expiration. You can understand, yes, there will be early diastolic murmur because as soon as when the left ventricle contracts, there is enough pressure, so the blood will flow into the aorta. But immediately as soon as the diastole starts, because of the regurgitation, blood will immediately flow back. So it has to be not diastolic, but yes, it has to be diastolic, but better word is early diastolic, because as soon as the diastole starts, some of the blood will go back into the left ventricle because the aortic valve is incompetent or regurgitated. You can get a systolic murmur also. Can you tell me why we should get systolic murmur? Perhaps because of the volume overload. See, normally what happens whenever the blood is flowing across a normal valve, there is no turbulence which is produced. But if the valve is narrowed, or somehow if there is more load, means more blood, so when this left ventricle will contract, this more blood will also give rise to a murmur, which could be physiological also in hyperdynamic circulatory states. But here, because of the volume overload, you can get a systolic murmur also, because most of the time the blood will come back here, you will have more blood at the level of the left atrium. So when it contracts, right, so it can produce a typical sound at the time of the systole. So we can get a systolic murmur also. We also get an Austin Flint murmur, which is a soft mid-diastolic murmur. Right? I will explain you what is Austin Flint murmur later. Other signs, we get a displaced heaving apex beat. Displaced heaving apex beat because of volume overload. We get a pre-systolic impulse. We get fourth heart sound. Fourth heart sound is characteristically seen in aortic regurgitation. You can get crepitations, which is because of pulmonary venous congestion. Auscultatory features of aortic regurgitation increase with hand gripping, and it is reduced by inhalation of amyl nitrate. You would appreciate this point. This is important. Why? Because when you are doing hand gripping exercise, the total peripheral resistance is increasing. So when the resistance is increasing at the level of the aorta, there are more chances of blood going back. So the regurgitation will increase. And whereas if you inhale amyl nitrate, this causes venodilatation or vasodilatation. So venodilatation or vasodilatation, the total peripheral resistance is coming down and more blood is flowing and there is less chances of regurgitation, so signs of regurgitation will come down. In ECG, it could be initially normal. Later, in the later part, you can get left ventricular hypertrophy and T-wave inversion. In the chest X-ray, apex is displaced down and out in severe AR. Cardiac dilatation may be seen in maybe aortic dilatation. There could be features of left-sided heart failure. Echocardiogram, there is rapid high-frequency fluttering of anterior mitral leaflet by impact of aortic regurgitant jet is characteristic. Now this is what I was just trying to tell you. See what happens, this is the mitral leaflet, and when there is regurgitation, so there is a jet of blood which comes and it hits the mitral valve like this in diastole, and similarly, so there is fluttering of the mitral valve leaflet in this condition, and because of which a characteristic murmur is produced, which I am talking about out here. So this is a characteristic murmur which you can get on echocardiogram. And you can also see dilated and hyperdynamic left ventricle. Treatment, yes, as far as the medical management is concerned, treatment may be required for underlying conditions such as endocarditis, syphilis, or severe essential hypertension. Aortic valve replacement is indicated if aortic regurgitation causes symptoms, and this may need to be combined with aortic root replacement or coronary bypass surgery. Patient has to be treated with digitalis, ACE inhibitors, and diuretics. Those with chronic aortic regurgitation can remain asymptomatic for many years due to compensatory ventricular dilatation, but should be advised to report the development of any symptom, especially breathlessness or development of angina. Asymptomatic patients should be followed up with echocardiography for evidence of increasing ventricular size. If this occurs, then aortic valve replacement should be undertaken. Systolic blood pressure should be controlled with vasodilating drugs such as angiotensin converting enzyme inhibitors. When aortic root dilatation is the cause for aortic regurgitation, example Marfan syndrome, then aortic root replacement is usually necessary. And time of operation is important. That is, after the onset of left ventricular dysfunction, but definitely prior to development of severe symptoms. So my dear students, when you are talking about valvular heart diseases, please try to understand, mostly in the MCQs, that where are the hidden hints where the examiner has given it to you. Whether it is clinical signs and symptoms or about the occurrence of murmur. If you understand the cardiac cycle and if you understand which valve is having a problem, you will definitely be able to time the murmur. Once you are able to time the murmur, and if you are understanding the pathophysiology, you will be able to understand what would be the clinical signs and symptoms which would be associated with this disease. Once you understand clinical signs and symptoms, because you have learned pharmacology a lot, you will be able to understand what should be the medical management, and finally you have to put your clinical equipment into place, that at what point of time we should stop the medical management part and we should go to surgical options. Thank you so much.